Hi, my name is Evelyn. This is my C-section video. So we have a laboring mom. She's trying to do a non-intervention birth, but it's not looking so good anymore. Baby's starting to have late decelerations, and so LND kind of informed me that we might have to do a C-section. So I'm just headed to my room. I'm gonna do an OR check and machine check. So my first thing is I'm gonna check my tank PSI for my machine. So my nitrous should be above 745, my oxygen should be above 1000 PSI, and then my pipe pressure should be around 50 PSI, and then I should fill my volatile gases, and I need to check the interlock system on them as well, and I just need to make sure the cap is screwed on tight if I refilled any of the liquid. And then I need to do a low pressure leak test, and then after that's done, I'll turn on the machine, I'll check my flow meters and my Link 25, and then I'll check my O2 analyzer for room air and for 100% oxygen, make sure that's calibrated, and then I'll check my CO2 absorber for the color, and then test my scavening system. Those all will pass, and then I'll do a high pressure system check. And that is just closing my APL valve and then pressurizing the system to 30 centimeters of water. And then if it holds for 10 seconds, that means it passes. Then I can test both the vent and the manual ventilation systems on my machine, and that will clear my whole machine. So then for my room setup, I'll need my common IV drugs. So I'll need midazolam, fentanyl, lidocaine, propofol, rocuronium, Sevo, and Zofran. And then some of my emergency Apples drugs, so atropine, succinylcholine, epinephrine, phenylephrine, and then ephedrine. And then because we're doing a C-section, I might need some extra uterine drugs for helping it clamp down. So I'll need Hemabate, Pitocin, Cytotec, TXA, Methadone, and then that'll just help in case she starts hemorrhaging and I need some extra backup drugs. So then other things, I'll have my blades, so I'll have MAC 3 or 4, and then a Miller 2 or 3, I'll have a glide scope, I'll have my LMAs, all my classic normal induction tools. I'll have an emergency airway cart just in case. But this is like a 20-something-year-old female, so I'm not super concerned. And then I'll have some ET tubes, so I'll just have a 7, and then I'll half size up and half size down, and then I'll have some LMAs, like I said, and then I'll gather my spinal supplies since we are likely going to do a spinal emergently because we're about to do C-section likely. So I'll have my 22 gauge spinal needle, my 18 gauge introducer needle, and then my spinal kit, and then I'll have my 3 mils of 1% lidocaine in my syringe with a 25 gauge needle for the skin wheel, and then I'll have a 15 milligrams of 0.75 bupivacaine in 8.25% dextrose with 15 micrograms of fentanyl for a total of 3 mils for my spinal dose. So once I have all that supplies, all those equipments, then I can go back and check out the patient and just finalize that we are doing a C-section. So this is a vaginal birth turn C-section. I have a 27-year-old female. She's 60 kilograms. She's an ASA of 1. She's a BMI of 24. She looks otherwise healthy to me. I would just listen to her heart and lungs, ask her a couple questions, look at her airway, ask about her history, if she's had C-sections in the past, if she's been pregnant in the past, does she have any past medical history, does she take any meds, does she know what malignant hypothermia is, does she have a family history of that, any allergies, and if she's NPO or not, if she's eaten anything while she's labored. And then I'll see if she's had labs done, CBC, CMP, her platelets, make sure she's not like super anticoagulated. And then I'd go over some things with the spinal and the C-section with her. So I'd go over the rationale. So this would just be post-operative pain control and also intraoperative pain control. And this will just help during the C-section for comfort versus going completely under and then not being awake when your baby comes out. So some indications of doing a spinal is that your pain is more managed during the procedure, and then you can also be awake when your baby comes out and you can do skin to skin and be present for that. And then some alternatives is you could not have the spinal. If we had time and we would do an epidural, or we had an epidural in, we could have relied on that. But since she didn't want any interventions, the spinal is the best right now. And we might be able to do, well, we might have to do general anesthesia as a backup, or we could do a combo. We could do combo spinal epidural. Some other alternatives are opioids, relaxation techniques, hydrotherapy. But at this point, because we're going to a C-section, spinal is the best option for her. So the procedure, she'll just have to either sit up and curl her back in a C, be like a shrimp, or lay sideways if she can't manage sitting up to do this. And then I would just do a little numbing in the back of your back, and then you just have to hold still the whole time and just tell me when you're having contractions so that I can place this spinal safely. And then some risks is that you could have nerve damage, hematoma or abscess, spinal headache. You could have a total spinal, which is too much sleepiness in your spine. And then backache, hypotension, this could not work. You would have nausea and vomiting sometimes, bradycardia or tachycardia. It might be really painful to place it. There's a small chance of infection, difficulty breathing or itching. All of these are kind of small chance, but could happen, just so you know. And then some benefits of this is that general anesthesia might not be required for surgery, and you would be more awake and more receptive when your baby came out, and you could have the skin to skin. And be present for that and remember it. So once I have gone over all of that with my patient, then I can ensure proper consent has been obtained, and then we can kind of go into this procedure. So now the OB is telling me that yes, we're confirming a C-section, and so now I'm just prepping her. So at this point I need to tell her to sit up. I'll make sure the patient's hooked up to monitors, and so we have SpO2, EKG, and she has supplemental oxygen, and then I'll make sure the patient's in a sitting position because she can tolerate it right now. So for the spinal, I need to start by identifying my landmarks. So I need to identify the intercrystal line or Toothier's line, and that is just the top of the iliac crest, and drawing a line across there, it should signal me to L3 and L4, the lumbar space. So I'm doing a midline approach. She's really young. She shouldn't really have, unless she's had back surgery, any issues. I shouldn't have issues with that. So I find this spot, and then I palpate, and then I'm gonna mark my spot with either my fingernail or like a cap of an IV. So then once I have that marked, then I can find my kit, open it sterilely, and then I'll don my gloves so I can access my kit. So once my kit's open, then I'm just gonna prep her back. So hold still, I'm just gonna put this cold prep on your back, do 3 circles. These go in the trash, obviously. And this is just either ChloraPrep or iodine. So then once that's drying, then I can prep my kit. So I'm just getting the 1% lidocaine, 3 mils of that in a 25 gauge needle syringe so that I can do the skin wheel. And then I'm gonna draw out my hyperbaric solutions. This is my bupivacaine, 0.75% with dextrose 8.25%, and that is for my actual spinal dose. And I am also going to draw up just like 15 micrograms of fentanyl as an adjunct in this, just to help with the pain. So since this is a hyperbaric spinal, I should see swirlies when I further on for this procedure. So once I have all of this drawn up, and I of course used a filter needle for that, now I can drape her because my prep is dry. So I'm telling her to hold still. I can get my skin wheel, so I find my spot, it's still there, numb the skin, and then I can get my introducer needle, and for stability I'm just going to hook it to the syringe, but you don't have to. So now I have my introducer needle. I'm going to say hold still one more time. If you need to have a contraction, I can wait, but confirm my spot, and then insert my introducer needle cephalad in between these bones in her back. Then once that's introduced, then I can use my Sprott needle, and this is all during the using the Bromage grip. So anytime a needle's in the patient, I'll use Bromage grip. So then I'll introduce my spinal needle, and I'll just advance that and then check for CSF, and then I'll advance it further, check for CSF, and at this point I have CSF backflowing, so I can take out this introducer little like filler needle thing, and then I can hook up my syringe, and then I'll just advance. I'll push half of the medication into the space after I draw back and see swirlies, because this is a hyperbaric solution. So the CSF will make swirlies, and then once I have the swirlies, then I can inject half the medication, and then aspirate, and then inject the rest of the medication. And like I said, it's just the 2 mils of the 0.75 hyperbaric bupivacaine, and then my fentanyl is my 15 to 20 micrograms is in there as well. Or you can use Dermamorph 200 micrograms or dexmedetomidine 10 micrograms. So once that's in, I'll do this really swiftly, but I'll take out everything as a unit, put it safely away, and then I'll grab my OR nurse, and we can swiftly put the patient into a supine position and then slight Trendelenburg to help the medicine go a little bit higher so that I get a slightly higher of a block. So Then once she's supine, I'll just wanna make sure that she has left uterine displacement because we're doing a C-section and also she's really pregnant, to optimize her hemodynamics. And then after that, the nurse will probably do a urinary catheter and I can assess to the block because it'll have been a couple minutes and the spinal sets up very fast. So then I'll assess and see if the block is working, and then the surgery can start and I can get blood pressure and I can have phenylephrine, a drip of phenylephrine going as a background for her blood pressure at 40 micrograms per minute to prevent hypotension. Earlier in the case, you could open her IV to do a bolus, but usually phenylephrine and medications help the blood pressure the best. So then during the procedure, I can chart the spinal and then I can continuously monitor her blood pressure and then walk her through the surgery. So say you might feel some pressure here, or your baby's out, your baby's been delivered, what time is it? And then once the surgery is complete, then I can give her a 30 unit in a 500 ml bolus of Pitocin to help uterine contractions. And I can also titrate my NeoAF if I used it at that point. So then I'll just continually monitor the patient still and keep getting vitals while we go back to L&D once the procedure's all over. And then I'll just chart the procedure again and kind of pass off to the L&D nurse. So I'll just say the patient had an emergency C-section after a desired vaginal delivery and the baby had late decels. So the procedure went well, the patient received a spinal, 15 milligrams of bupivacaine and 0.75%, and then 15 micrograms of fentanyl an hour ago. Pitocin was also given, Neo was given for blood pressure, the patient's comfortable, the Neo is off now, and the vitals are within range, and the patient required about an hour or more of continuous monitoring. So please watch for hemorrhaging, and if you have any questions, let me know.